Okay, so hello and welcome everyone. Really happy to see you here this afternoon for our Cochlear Center research seminar. My name is Jennifer Deal. I'm the interim director of the Cochlear Center here at Johns Hopkins. And so we're really fortunate today to welcome Dr. Walter Wittich, who will be talking to us about what can the WHO ICF teach us about functioning with a vision and or hearing difficulty. As we get started, just a couple of reminders related to the logistics. So there will be questions and answers after the presentation. If you are online, please use the Q&A feature and we'll ask the questions on your behalf. If there's a burning question during the talk, Dr. Wittich has let us know it's okay to ask, but otherwise we do ask you to hold those questions until the end. Closed captioning is provided in the Zoom, and so there's a link here to access the transcript. To let everyone know, this seminar will be recorded. And if you do have any technical difficulties, please feel free to reach out to us at jhcochlearcenter@jhu.edu. And so Walter is our second seminar speaker of the year. So we ask you to please save the date for these upcoming seminars. And in particular, we want to remind you that our Cochlear Center Annual Research Day will be held on Friday, April 17th. Starting at 9 a.m. to 4 p.m. We'll have a keynote address by Malaz Mustani around noontime, and we'll also have the ability for posters and other engagement with our trainees in the afternoon. So please do plan to join us for that research day. And so now it really is my great pleasure to introduce Dr. Walter Wittich, who is an associate professor at the School of Optometry at the University of Montreal in Quebec, Canada. His research focuses on the rehabilitation of older adults with combined vision and hearing loss. His research domains include basic sensory science, as well as medical, psychosocial, and rehabilitation approaches to sensory loss. He is the inaugural chair of the Deafblind International Research Network, the 2020 recipient of the Canadian Helen Keller Center Award. He's a fellow of both the American Academy of Optometry and the Association for Research in Vision and Ophthalmology, and is Quebec's first certified low vision therapist. Walter, we're really so glad to welcome you here today. Thank you.
Thank you, Jennifer. You're most kind for the introduction, and thank you for having me as part of the series. It's super exciting. I'm going to share my screen to tell you all the things that I want to tell you about, and we'll jump right in. In the tradition of Canadian research, I would like to begin by acknowledging that I'm speaking to you today from Montreal, which is located on unceded Indigenous lands. The Kanien'kehá:ka Nation is recognized as the custodians of the lands and the waters from which I present today. And Tiohtià:ke, which is commonly known as Montreal, is historically known as a gathering place for many First Nations. Today, it is home to a diverse population of Indigenous and other peoples, and I want to express my respect for the continued connections with the past, the present, and future in our ongoing relationships with Indigenous and other peoples within the Montreal community. And if the idea of unceded lands is of interest for you, I invite you to check out this website, www.whosland, because it gives a really beautifully detailed overview of a different way of looking on land division across North America. I'm also going to take a moment to say thank you to the various people that give us money for various things. Turns out I don't have any conflicts to report for the materials that I'm talking about today. Now, I thought, given that you guys are all into hearing things, I would start out by giving you a mini definition of deafblindness, because I live in this bizarre shared space between vision and hearing, and we're not always talking about the same thing. And turns out my favorite definition is the Nordic definition of deafblindness, which has been around for quite a while. Deafblindness is a distinct disability, and it is a combined vision and hearing disability. It limits activities of a person, and oops, I'm sorry, my slides are being difficult with me today. Give me a moment. And it basically affects participation in society to such a degree that society is required to facilitate specific services, environmental alterations, and/or technology. So you see that this is a definition that is very much focused on functioning. This has been adopted by the World Federation of the Deafblind, which is an organization created and run by individuals with deafblindness, as well as by Deafblind International, which is an organization that predominantly consists of professionals working for people with deafblindness and with people with deafblindness. So the Nordic definition is widely accepted, but there are different ways of doing this. Many of you are familiar with what we would call the medical model. These are usually eligibility criteria, right? Here we're talking about things like audiology thresholds, pure tone averages, contrast sensitivity, visual acuity. And these are just very specific measures that really shrink down to what can the eye and the ear do. There are other ways of doing this within a psychosocial model, which is really the definition that I was just talking about now. The Nordic definition is interested in function. But there's a third dimension that I quite find interesting, and that is self-report. Who actually identifies as living with a combined vision and hearing difficulty, and what do they call themselves? Because not everybody will be comfortable with the word deafblind. If any of you work with people that are older and who have age-related combined sensory loss, we often talk about dual sensory impairment, because it sounds less threatening, right? There's less deafness and blindness, but there's reduced vision, reduced hearing. It's also that for many older adults, their identity is not necessarily linked to their sensory level. So there are different ways of how to look at this. And so in a medical model, you would look at thresholds. And from that perspective, actually, I think it's very useful because eligibility criteria are important in our personal lives. Functionally, though, this may or may not correspond to something, and there's great variability in here. You know, somebody may be a proficient Braille reader and may do well with their 2 hearing aids, right? So they may function actually quite well, even though they're not necessarily at full capacity. But what they call themselves may not at all be deafblind. So just as a mini introduction of how I perceive deafblindness as a topic. Now, the context for today, and also the context of a lot of the work that I've been doing lately, is the International Classification of Functioning, Disability, and Health. And it's a model that was created by the WHO. It basically looks at any given health condition and therefore identifying a disorder or a disease. And in our case, that's deafblindness. If any of you are familiar with the ICD, the International Classification of Disease Codes, it actually turns out that there is a code in the system for dual sensory impairment, even though it is not linked to a specific disease. And so now you can see how this disease may cause impairments in terms of body function and structure. It may cause limitations in terms of activities that are available. It may cause restrictions in the ability to participate. And these effects are all influenced by environmental factors and personal factors. And you can see in the model that all the arrows are pointing in all directions because this may all influence each other. Now you can basically use any research concept, any question, any idea, and place it inside this biopsychosocial model. This is really why this model was created. And so we can look at something like assistive technology, which would be considered an environmental factor, and how it facilitates or communication, which would be considered part of participation. Now, behind this model, something that's sort of the next level up in terms of ICF is the categories. This used to be known only as the famous red books, but this also now exists as a browser online. The ICF browser is basically a web page that gives you access to the entire coding system behind the ICF model. It is divided into 4 domains. That's the domains that are all in the model I just showed you. You will see that the personal factors are missing, and I will come back to that a little bit later. Each of these has a very defined definition, detailed definition, and you can look up exactly what means what. And so if we look, for example, into body functions, There are various subcategories, mental functions. The ones that is relevant for us today, of course, is B2, which are the sensory functions. And within sensory functions in pain, we have specific categories on seeing and on hearing. And how these codes and these categories work, I will show you a little bit later. What is interesting is that if you have too much time, you can now go deeper. And within hearing and vestibular functions, you now get specific codes and definition of what is sound detection, sound discrimination, sound localization, and so on. Same thing for vision. You will already see that the vision coding system is somewhat more detailed. There are more codes allocated to vision. And yes, that is a problem, and we can untangle that a little bit later. Now, you thought you know everything about the ICF. Now that I've told you how this works, here is sort of a mini overview how you have component levels, this being body structures, body function, and activity and participation that are exploring the functioning and disability of the individual. And you have contextual factors, which are the environment and the personal factors. They are now presented on different levels. And don't worry, I'm not going to take you too deep down, but I just want to show you that there are multiple levels of how these categories work. They are divided into chapters. You've already seen I was talking about B2, the chapter on sensory function and pain, and how underneath now you have level 2, 3, and 4 codes, depending on how detailed you want to be. This also applies to environmental factors, for example. But then there's this mysterious category of personal factors. These are things that don't have a category. They don't have a code. They're simply unique to the individual. And that's probably an entirely separate presentation. The ICF has decided not to give a coding system to the personal factors because they vary too much. But they are still relevant because if any of you are involved in individualized and personalized medicine and rehabilitation, it is, of course, the personal factors that play a huge role. So far, so good in terms of your overview of how these codes and categories work. Now, let me tell you about a core set. The problem here is that the ICF has over 1,400 of these categories. And of course, nobody can memorize this, and it becomes completely ridiculous to apply this system. And I will have a separate slide of why anybody would want to anyway, right? But we'll get to that. So core sets are an interesting idea because they are a subset of a reduced number of categories that are specific to a disease. And the purpose really here is to have a clear and specific terminology that tells you about a specific disease, and that this terminology then globally is used everywhere, right? And therefore facilitate communication. Now, in order to develop such a core set, the WHO requires preparatory phases. The empirical study looks at the pure assessment context of using these in an applied setting. The systematic review looks at the perspective of researchers that work in the domain. The qualitative study considers the priorities of functioning of individuals that live with that specific disease or impairment. And finally, there's a study where we do a survey with specialists in that specific domain. The purpose of these 4 studies is to figure out what each of these perspectives believe are functional priorities, right? The ICF, the key here being F, functioning. This is all about functioning. What are the functional impairments? What are the functional priorities? What do we need to know about living with this condition? Once these 4 studies are done, there's an international consensus conference. This might be a good time to point out that the WHO always requires efforts to represent the entire planet. The WHO is divided into 6 regions. So when you conduct a study of this kind, when you want to develop a core set, you aim to have representation from each of the 6 regions of the WHO and to have consensus among all these regions to then develop a core set and its final content. And once that is done, of course, it gets really fun because then you want people to know about this and you want this to be implemented. And I will show you at the very end of my talk today of how we've been working on implementation as well. So why? Why would anybody do this? Why would anybody look at 1,400 bizarre categories with letters and numbers? And what is this all about? Now, for some of you who work in policy, you may be aware that there are people out there that have all sorts of power. For example, people that make decisions about coverage in insurance companies. People that sit in ministries that decide about policy of what may or may not be funded this year, or what may or may not be a priority within healthcare of any kind, or in this case, also education, since deafblindness also affects a lot of children. But the problem with many of the people in these power positions is that they did not study sensory care. These are not, or rarely, audiologists or ophthalmologists or optometrists. These are not always people that have any kind of medical training. So they make decisions over healthcare without having training in healthcare. And many of these places then look to standardized and centralized data to inform them what the priorities should be. And it is interesting that the ICF core sets are often used for this purpose, especially by governments, but it also turns out that funding agencies look towards these documents, non-for-profit, NGOs and other government organizations, even health and social service providers. But the focus that I want to bring today is that this can also be used by researchers to identify priority areas of functioning that we're not actually studying. Keep in mind that the development of an ICF core set considers people living with the condition, people that work in the field, and the current research that is available on this area considered within a clinical context, right? So you have the entire picture around the entire planet. So it's a one-stop shop by trying to figure out what we should really prioritize. There are existing core sets. They exist on all sorts of various aspects of health. I will let you explore this on yourself. What might be most interesting to you is that a team based in Sweden under Sarah Granberg developed the core set for hearing. I'd be very curious to find out in the question period if any of you have actually ever looked at it, but I will show you some examples of this later today. There's a team based in the Netherlands that currently just finished the process of the development of the core sets for vision. It's Lorenzo Billier's PhD project, and he will defend sometime in the spring. So this is almost done, but they are already published. And we've been finishing the process of the deaf-blindness core sets, which were published this February. So as a mini reminder, the WHO doesn't do anything unless it represents the planet. And so for the project that I show you today, we actually had to get various ethics approvals across different continents in order to cover this. Separate question for answers later on in case you want to go deeper there. The first piece that the WHO requires for anything and everything is a systematic literature review. Without doing a review, the WHO does not pay attention. So we conducted such a review for the purpose of determining how functioning is measured in deafblindness currently and what kind of measures are specific to deafblindness. So it turns out some of these you might be familiar with, the Center for Epidemiological Studies Depression Scale, the Mini-Mental, and the Lawton-Brody were the three measures that were used the most often, but I need to qualify here that the ones that I am listing here have to be measures that are available without cost. This is another one of those WHO things where you have to make sure that whatever we present as potential recommendations has to be accessible anywhere on the planet. So if these are things that cost money, that takes half the world out of the picture. And so these are the three most commonly used measures that are available without charge that have been used in research with deafblindness. But what you will probably already have figured out is none of these three things are in any way designed or adapted to be administered to people that are deafblind. And that's, of course, a problem. We only found three measures in the literature up until last year. There's been a fourth one that came out last year that are specifically designed for people with deafblindness. One of them is the Inter-RAI Community Health Assessment, or the Inter-RAI CHA. It has a deafblind supplement with just over 50 items that are specifically considering vision and hearing together at the same time in the same person. It's a very interesting third-party health assessment. If you have no experience with the Inter-RAI measures, very rich resource to look into. The Go CC for All is a survey that was specifically designed in a study to access television. And then there's the Usher Lifestyle Survey that was created specifically for people that live with any of the many types of Usher syndrome, one being of the largest groups of people living with deafblindness. Now, I want to introduce you to the idea of linking. That is because linking is how we now bring the content of our studies into the context of the ICF coding system. The way this is done is that, let's say we have a question. Here in this case, we ask somebody a question about environment and about environmental barriers. And the participant answered, what's a bad climate condition, especially cold time, whereby fingers fail to work in a smoothly way. Can tell you already, this is not somebody who has English as their first language, but that doesn't actually matter in the context of our coding, because we're not so much interested in how things are said, but we're interested in the context behind them. And that also does magic by doing research across, in this case, easily over 25 different languages, because even when it's all translated into the core language in which we did the analysis, the content remains, and the actual phrasing itself is not that important. So we start out by looking for the meaning unit. That is basically, in this case, the sentence that we got. And now we need to reflect on what is the meaningful concept in here. It turns out there are two. One is the effect of climate, and the other one is the effect of cold weather on finger movements, right? So in a way, we've now reduced the participants' response to two specific concepts. And now I go into the ICF and I find the categories that are responsible for this. And it turns out in environmental factors, E225 gives us a code for climate, and B265 is the code for touch function. So now I have reduced or transformed the participant's response into the coding system of the ICF. What do I do with these codes? I do some summary statistics. What you see here now is the proportional distribution of the number of codes that we needed to use to code the content of the entire systematic literature review. So you see, for example, that there is a large number of codes that we used for B1, which is cognitive functioning, and a large number for B2, which is sensory function and pain. This makes a lot of sense when you look at the idea that cognition is important in the development of children with deafblindness. Cognition plays an important role in maintenance if you look at older adults with deafblindness. And of course, the vision and the hearing codes would come up a lot because we're dealing with deafblindness. So now it gives you an overview of where the literature basically says these are functional priorities, because that's where the bars are thicker. But I will come back to this to tell you more what we do with this later on. The second study we did was a qualitative study where we basically interviewed people that are living with deafblindness to ask them these questions about what is important to them. You can already imagine that this is an adventure to do a global study doing qualitative interviews with people that are deafblind. The World Federation of the Deafblind, Deafblind International, and the European Network helped us a lot in terms of recruitment and identification. We ended up finding 26 individuals and 9 focus groups for a total of 72 individuals from all 6 regions of the WHO that helped us out by conducting these interviews. And for the ones that were done individually, they were done over Zoom. The focus groups were done in person and then recorded and transcribed. Interesting distribution across different regions of the planet. You know, Canada, Mexico, Australia, Spain, UK, France, Zambia, Egypt, India, Nepal. Now, it is clear if you're doing hardcore science, this would never be representative, right? This is not a very large sample. But in the end, The WHO is forgiving about this as long as somehow each region is considered and represented. So of course, ideally, we would have hundreds and hundreds of participants, but this is not always feasible. It's not always possible. Here are the questions we actually ask in case you want to go into detail. They are provided by the WHO. We ask about how people perceive their body functions and which structures of their body are affected by living with deafblindness, which activities and participations they can and cannot complete, what they perceive as their environmental facilitators and their environmental barriers, and whether there are items about themselves that they believe make life harder or easier. Now, we then do a little bit of stats, and at Hopkins, I'm not worried. I believe that you are most capable of doing these things. These are really all descriptive stats. We basically have to count the number of codes that are used during the coding process, during this linking process, and then we do some summary statistics. So this is not really very advanced. Here now, we have the proportional distribution of the priorities as identified by people with lived experience. Fascinating. What does it mean? Well, it really only takes on meaning when I now compare this to what emerged from the literature review. There are some statistical ways in which I can compare these frequencies. I'm not going to bore you with that today, but I'll show you a couple of examples. Something that I found really interesting is that mobility itself was the largest component of codes in activities and participation for people with lived experience. This is a priority for them functionally. But when we look at that same category within the research literature, this is barely researched at all. Why this may be, I have some theories, but here's a clear discrepancy between what people with lived experience need and want versus what we are actually doing in our labs. Here's another example. We look at the distribution of things across activities and participation in the literature. We study learning. Makes sense. It's a priority for children. We study communication. Also makes sense because, of course, intuitively in deafblindness, that's a big deal. And then there's a lot of research on interpersonal interaction and relationships. This includes family dynamics. This also includes family support systems. But when you look at lived experience, they don't really differ all that much in their importance, right? So why do we study these three things and not so much the other ones? And the answer to that may actually lie in what we can get funded. Because it is easy, I believe, from my perspective, to justify to a ministry why we would need to study learning and facilitate communication and look at the role of family in care provision. And money, research monies will be made available for this. And so sometimes, this is where we need to find this balance. Are we doing what we can because we can get money for it? Or are we doing what we should be doing according to the people that live with a need? Interesting also in the environmental factors, people with with deafblindness identified systems and services, in brackets, the absence of systems and services, as a priority. Whereas when we look at research in environmental factors, it's about technology and accessibility. Again, probably easier for us to write and get a grant funded that looks at products and technology. The third component of building such a course set takes in consideration the perspective of the experts. And so here now we're looking at the people that work with people that are deafblind. This is an online survey. The questions are the same. We were very surprised that we got over 700 responses within 3 weeks, only to find out that almost 500 of them were incomplete because, there were a couple of bots in there as well, but people would complete the yes/no questions, but would not actually write anything about their perception of functional priorities in this profession. And so we ended up selecting a stratified sample of 105 responses where we had written responses to spread this out relatively equally across the WHO regions, to have as many countries and professions represented, and to also look at responses that were more than 2 words long so we could do something with data. Here, a quick overview of how people responded from different regions of the world. It is not surprising that the Americas and Europes are usually a little bit overrepresented. It has to do, with knowledge and access and service provision. But I was ecstatically excited that we got 3 professionals from Egypt in here as well, just to have the Eastern Mediterranean represented as well. Great distribution of professions across the fields and across the globe. There's a big chunk down here that I call educators and others. So this is actually people that provide education for children with disabilities. They play an important role in this distribution as well. Otherwise, I'm relatively happy with the distribution of data. It's always nice if we would have more, of course. Here now, comparing the expert survey with the literature review. Are we studying what the experts believe? I found it interesting again that we're looking at this distribution. The experts were much more equalized across the aspects of activities and participation, much more aligned with the people with lived experience. But a big difference in environment. Here, for example, the experts prioritize support and relationships. And just qualitatively, what I'm throwing in here for you is that we've done a comparison of high income versus low income countries. And it's very interesting how, especially in low income countries, there's a priority on the role of family, friends, and community, simply because there's an absence of certain systems. And so the care gets taken over by people in the environment because it is not available within the system itself. So if you are wondering what you should do, where you should work, what kind of research in deafblindness you should be doing, according to the professionals, we would really look into the role of support and relationships at the family level, but this also includes health professionals and specifically here, the code for other professionals, which also includes sign language interpreters and interveners, so people that facilitate communication. There's very little research going on that domain. If you look at the perspective of people with lived experience, I talked already about mobility. Some of this has to do with transport, but some of the codes that emerged also are linked to tactile communication. So this is where we find a little bit of overlap in the communication codes and the mobility codes. And then, of course, systems and services and policies were a great priority for people with lived experience in the global north, because there should be more, in the global south, simply because they are absent. So now, in this story of building a core set, we then conducted our consensus conference, and that was done October last year. It was a really interesting experience because, again, the mandate is to do this globally, right? And so how do you come to a global consensus this way? We started out with an online consensus survey just to get a start on things that we are easily agreeing upon. And we then organized an in-person consensus conference in Spain, just outside of Barcelona. And I'm still stunned how we managed to bring 29 people from across the planet that represented all of the phases that we conducted to come to Spain to do this conference with us. But the driving reason here to do this in person is a communication issue, because about a third of the panel were people with different levels of vision and hearing difficulties. And it is only in person that we would be able to overcome all these communication barriers. So we spent 2 entire days conducting this consensus conference with great focus and also great grant funding support to overcome communication difficulties during the process. Of course, it was also in Spain, so we were having a great time. Now here, just to give you an example of how this consensus ended up happening, we would present a code like E115, which is Projects and Technology for Personal Use in Daily Living. This code was up for discussion, up for vote. Is it a priority? Does it belong in or not? We would then also present another code that was already included. And so here the question was, we've already given an emphasis on a code that focuses on assistive devices? Do we need a second code that also looks at general devices, for example, mainstream technology? And we would then literally in the room vote with little paddles, yes or no, and the higher number was winning. This is a visual display of the gang that all came together from all regions and corners of the planet. And about, I want to say 6 people here are living with deafblindness themselves, their communication support. There are parents of people with deafblindness here, professionals, policymakers, researchers, everybody was represented in some way or shape. The day after, we went to Barcelona to present the core sets for the first time. In this case, there was representation of the government of Spain and of Catalonia, and that was basically our beginning of implementing and distributing thereafter to see where we go now. Just for the fun of the context of it, I put together this tiny presentation to list the countries that are represented in the creation of these core sets from the different WHO regions. Now, we did not have survey or participants, or not every phase was represented in every region from every country, but by merging all phases, at least one phase was represented by at least one of these countries. In the African region, here in the Americas, from all the way North, Central, and South America. Strong representation from Southeast Asia as well, given that half the world lives there. We had a lot of countries represented from Europe. This is also biased a little bit by the fact that the ICF is very popular in Europe. And then we had representation from the Eastern Mediterranean. This is always tricky, given that it's politically not always very stable, but we did manage to get access to some data from this part of the world. And we also had lots of representation from the Western Pacific region as well. Now, I don't mind sending you guys the PowerPoints in case somebody would like to have a look, but otherwise I would encourage you to take a screenshot right now. These are the 3 QR codes for the 3 core sets that emerged from our process. So after 4 years, we came up with the comprehensive core set, which is 218 codes. And the purpose of the comprehensive core set is really to facilitate communication among different fields of care. And also how to communicate with people outside of the field of care, as in such areas like policy planning or grant allocation. The intermediate core set is a little bit shorter, 137 codes. This is really more about the communication between healthcare professionals to prioritize what we need for care provision. And the brief core set is a concise version that really focuses in on the individual clinical encounter, because these 33 items are really the starting point of what you would want to explore in terms of functional ability or functional priority in an individual that is living with combined vision and hearing difficulties. Now, turns out we already have core sets for hearing loss and vision loss. So Lorenzo did a little overlap figure for me a little while ago, looking at the comprehensive and the intermediate core sets for the different sensory difficulties to see which parts overlap. And so you see that there are some sections where all sensory impairments are sort of in agreement. There are some that are shared by 2. There are some that are not shared at all. It's an interesting exploration to look at that. And so I decided to look at these 3 core sets, which you can also easily access for free because they're all available online. And we'll take a closer look at how they overlap. I don't expect you to be able to read these because these are the actual codes and their descriptions, but I just want to point out a few patterns here. So for example, all 3 core sets, hearing on the left, deafblindness in the middle, vision on the right, mention in their brief core set, right, that those are really the functional priorities, some aspect of seeing functions, right? So that is important everywhere, and it's somewhat intuitive, right? But it turns out that the hearing functions were only prioritized in hearing and deafblindness. It was not prioritized in vision. And yes, Lorenzo and I will have a deep discussion about that during his PhD defense in March. Also interesting is that the vestibular functions are represented within hearing and deafblindness. This makes some sense. Hearing and vestibular function are linked. So that is intuitive. Now, if we look at activities and participation, the items that are related to each other, that are similar, are about listening and communication. The ones that are shared only with hearing and deafblindness are about stress, so some psychological functioning, spoken messages that make sense, family, education, and community life. It's really interesting how now the difficulties in hearing are represented in activities in education and community life that, of course, often heavily rely on the ability to hear, the ability to communicate, whereas this did not emerge in the core sets for vision. However, deafblindness and vision share things about purposeful sensing, and here very obvious transportation, right? Because transportation means travel, independent mobility, and the acquisition of goods and services, which is much more impaired by the visual impairment than it would be by a hearing impairment. Looking at the environment, also a couple of interesting things. The first one is that products and technology used in daily living are mentioned everywhere, right? So this is a general agreement. It matters how you can integrate technology into your sensory impairment life. And for hearing and deafblindness, they highlighted the importance of other people. Now, whether that is family, whether that is health professionals, friends, care providers, that seems to fall more into a priority than it does for people that were living with a vision impairment. And we also have a couple of items on attitudes and policies. I thought that that was interesting, that societal attitudes, this also goes into the world of stigma, seems to be a bigger deal in hearing and deafblindness than it is in vision. However, I do need to qualify here. I'm looking at the core sets, meaning the brief core sets, meaning these are the shortest ones, the highest priorities. It turns out most of these things are shared when you look at the comprehensive core sets, which are much more detailed and also longer. And then the final one here is physical attributes. It's interesting how in hearing and in deafblindness, people mentioned the importance of sound, light, and vibration simply as a tool, an environmental stimulation that is important, makes sense for the context of communication as well. So now that we've done all of this, I wanted to show you a few early signs of how these things are starting to be implemented. Of course, we've only released them in February this year, but they have since then been promoted on the website of the ICF research branch of the WHO, and they're freely available through the Open Science Framework, which I showed you the QR codes earlier. We have been able to create summary videos that are available in American Sign Language, and we're currently, actually this coming Saturday, filming the Quebec French Sign Language version. We also have released the text and the content of these videos to our collaborators to create parallel versions in other countries as well. In Spain, I mentioned earlier that we already presented this to representatives of the government. In Sweden, some of our team members took this on themselves to translate the core sets into Swedish, and they are now developing assessment tools in Swedish that are specifically centered around the ICF core sets, or they are using existing assessments and making sure that all items are represented or which items they may need to add. My favorite implementation right now is probably coming from Poland, where I received an email a little while ago. There are currently no services for deafblindness in Poland. It is not recognized as a type of disability. People with deafblindness get services for vision or for hearing, but they're not coordinated, and there is nothing available in the domain of tactile services, for example. And so the deafblind community leaders in Poland got their hands on this document. They have translated this into Polish, and they did a signature collection among the deafblind in Poland and submitted this to their Ministry of Health as a sign that Poland needs to step up to join the rest of the world in their service provision to recognize deafblindness as a unique disability. So this is one of those things where you're going, that's why I wrote that grant. Now, the next piece, of course, in the implementation, there is something else that the WHO does that I found very interesting. They clearly recognize that it matters if you are a youth or child with this difficulty versus an adult. And so there are separate and specific core sets that are being developed for children. Our efforts were across the lifespan, but it turns out I have a very dedicated PhD student now who has taken this on to create the core sets for children and youth. The systematic literature review we will submit later this year because that's already done, and she's starting the other phases in January. So hopefully in a year and a half, we will be able to present you the core sets for children and youth with deafblindness. There are lots of people that have given us money for doing these things, so I always want to say thank you. And I also want to point out there's a website that we created, Who is Deafblind, to share things as they come up. So that is something you can always log into if you feel like it, or email me if you have other questions in and around this. And that is my story. And I would love to answer some questions or discuss this in a little bit more detail.
Are we unmuted? Walter, thank you so much. That was such important work and yet also such a really excellent presentation. Thank you so much for walking us through that. Dr. Moises Slow is online, and that was his first comment too. Just what an excellent presentation this was. He had a question about the role of age, which I think you started to address a little bit in that last part there, talking about the difference between children and adults. But he had another question, and that has to do with your systematic review of the literature. And so he was wondering about the potential role for any kind of publication bias in that review.
Yes. Oh, publication bias, of course, always multiple problems here. For example, one big problem is not only our regular publication bias that certain things don't get published, but what I think is a big issue here is that the large majority came from what I'm going to call the global north. So these were high income, high resource regions. That's where most of the publications come from, right? That's just how that works. We've run into a couple of methodological barriers that are simply based on resources. Also interesting, when we, for example, reach out to people with deafblindness in poor countries, the ones that are identifiable or that are able to participate are often the ones that themselves have resources. They've already been overcoming their own communication barriers, or they are community leaders, right? So their experience is not the same as the experience of Joe Blow on the street who is living in a hut somewhere in the middle of a field. And it's become a big challenge for us to try and get a spectrum going. So in terms of the systematic review, definitely an issue, because not all countries, not all WHO regions are equally represented. That I will easily admit to that. And we don't have an easy solution to this, right? Because what are we going to do, right? It's really interesting. On the flip side, in my world, it has become more and more complicated to get ethics approval for anything, right? There are a million reasons of why we have to be careful, and I get that. I'm not against it. But for example, collecting data in a low resource region has become very easy as long as they have Wi-Fi. I can conduct a Zoom interview with somebody in Niger if they're interested, because I can get approval at my institution. I don't need necessarily a data sharing agreement with an organization in a country where they don't exist, right? So sometimes some of these procedures are actually easier to complete in the global south, but they need to then be driven and funded by somebody in the global north. It's a complicated story to balance this out.
Are there questions in the room? And we do ask if you please use the microphone just to make sure everyone online can hear.
Or it's best to talk into it. Hello, Dr. Wittich. Could you hear me?
Yes, excellent. Thank you.
Thank you so much for your presentation. It is wonderful. And so my first question is, so I know people are qualitatively review the data, review the items, and what if there are some, some conflicts among within the groups, and how would they, some people would say, oh yes, I prefer this on the core set, but someone might say, oh, I don't think this one would be in the core set, and how do people like handle this and make a decision on this? Thank you.
So I can tell you a little bit more about the 2-day experience of our consensus conference, because that's really what we were doing, right? We were hashing it out and people were discussing, and they were not always very friendly with each other. Some people wanted everything included because everything is important. And other people really understood that if you have a list of more than 30 people, more than 30 items, nobody is going to pay attention anymore, right? The ICF is difficult because it has so many categories. So if we present a document with too many categories, we have failed our mission of creating a course set. So what we ended up doing is we went about this very systematically. The first step was our little online survey where we said, tell us if you think this is in or out. Just not too much thinking. Do you think this is a priority, yes or no? And the items were 75% of the people or more said yes, or 75% of the people or more said no. They were immediately removed from discussion because obviously we have sufficient agreement. So in Spain, we only looked at the items where there was some agree, disagreement, and we weren't quite sure whether they belong or not. And then these items were specifically sent to everybody, and we said, think about these. These are the ones where we will ask you in Spain whether they're in or out. And if you want them in, you have to have a good reason. And if you don't want them in, you have to have a good reason as well. So then we went through the entire exercise again, item by item, but that was now with our little paddles where people had to vote yes or no. We quickly counted and calculated those proportions again, and we told them ahead of time that we're using the same threshold, 75 or more, 25 or less. Once that was done, we had those 218 items that we considered in the comprehensive course set. But we also understood that that is too much. So we went through 2 more steps where we said, here's everything that everybody agreed on. Here's the stuff that we believe you should focus on if you're in an applied context. Because, for example, one of the items in the complete one is the ability to vote in an election. We included that in the comprehensive course set, but that's not really something you would be discussing in a clinical encounter, right? Voting is sort of a level up of complexity and importance. So in the comprehensive, it's there. In the intermediate, it is not. And then from the intermediate, we shrank it down to the 30 items that had the highest level of agreement. In terms of the numbers that we had from the voting, we actually had to discuss 2 of those items, whether they're in or out. And so we decided, let's keep them in. So those are the 33 items. They were simply agreed upon the most. There were very few that were agreed upon by everybody. And you will also see that in the brief context, in the brief course, there are no items on body structure, because we removed that because this is kind of assumed we're already in an environment with a clinical encounter one-to-one. We know that vision and hearing are affected. We don't need to ask it. So those 33 items are only about function, participation, and environment. I hope that answered your question.
Yeah, that surely answered my question. Thank you so much. And here comes the follow-up questions on this. So maybe in the future, would your group or any other groups kind of thinking of extend their research on, quantitative data? I know right now maybe the data set is not that much, but maybe in the future, I know there are some, methods like item response theory that can calibrate the items into a smaller item set. So do you think in the future any groups would do that kind of things?
Yeah, it's a wonderful idea. I have a postdoc who has applied for a grant to do exactly that. We will find out in April whether this is funded. What we've decided to do, deafblindness is complicated because you've got so many subgroups. You have sign language users, you have people that communicate orally, you have people that are age-related in their impairment, there are people that are entirely tactile. So there's great diversity in this group. And so this postdoc of mine is proposing to actually validate the core set, in this case, the brief core set, only with sign language users and only with older adults, to see what happens if we apply these same items in an assessment to very different populations in this group, and see maybe there are a couple of items that we can let go in aging, or that we may have to bring in aging, and things that are irrelevant if you are a sign language user, but other things that need to be prioritized. So yes, it's a great next step to do. Thank you.
Good afternoon. Thank you
Hello.
for a very insightful presentation. While you were talking so much about these core sets for function, a strong parallel came to my mind about core outcome sets, which are a little more clinically focused across a diverse range of outcomes and not largely about function and environment. And they tend to be more disease focused. But I wonder whether, in your perspective, there's a stronger connection than that between the two types of core sets, the core function sets and the core outcome sets, and whether one can feed into the other within certain disease areas or even across disease areas. So curious to hear your thoughts on that. Thank you.
So I think that that's a wonderful question, especially because I'm somebody who truly believes into this idea of a biopsychosocial model of health. I think that none of these three can live without each other. Now, these core outcomes, like you said, are often used in a medical setting or in a more disease treatment context. Whereas, quick detour. I submitted a grant where it was criticized in the grant that our patients don't do this and we don't know that about our patients and there's da 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 da. The entire review was about us and our patients. And then I was given the opportunity to write a rebuttal because I resubmitted the grant in the year thereafter to get our consensus conference funded. And I said to the reviewer who was telling us about these 17 things that we are not doing with our patients, these are not our patients. These are individuals living with a disability. Some of them haven't seen a medical professional in decades because they are not treatable. And it is because of that that they don't consider themselves patients. They're just individuals that are living with deafblindness. They are not ill. They are not here to be healed. Therefore, this grant is not about patients. It is about individuals that are living with a difficulty in vision and hearing. And so all the things that an outcome assessment looks at are improvements in, anatomy, physiology, and function. So when we get to the point of functioning, that is where I think the core sets of the ICF have a role to play. If something like this, like core outcomes and ICF core sets would merge, then I would say here are measures that are specific to changes in anatomy and physiology. And here are measures that are sensitive to changes in functional ability, quality of life, and independence. But the problem is that sadly, this applies to Canada, the US, and many other places, in some of our approach to the training of the professionals that are in these domains, we are still a bit siloed. And so my experience, some of my best friends are medical professionals, but we love a good argument about things like anatomically successful surgery. And I'm going, who cares if your surgery was anatomically successful if the person is now blind? This is really where we have very different standards, and we need to blend these standards and consider them, tolerate them. Yeah, I have to respect the importance of anatomy, but they also have to respect the importance of functioning. And then I think we have a chance of merging these measures as well. Does that make sense?
Absolutely. And I don't know whether you could see me, but I was nodding vociferously from back here. But in just a quick comment in response to that, I fully agree. And in the core outcome set world, we are increasingly trying to push towards, let's make sure that our sets include more function-related outcomes, more patient-reported outcomes that capture exactly what you're talking about, the patient experience over and above, like surgical success. Or in addition, or at least not exclude the patient experience at the expense of something like surgical success. Yeah. Thank you.
Thank you. Thank you.
I love this conversation so much. Thank you, Walter. And I think I have a question too, which is maybe a little bit bigger picture. And so as you mentioned, even in your last response and where you started out was by thinking about that biopsychosocial model. And that really sets the framework for everything. And then there are some in the disability community who think it's that model and to think about.
I'm sorry, I lost you. I lost your sound. I lost your sound.
Oh, is that better?
Yes, that's good.
Is that okay? I'll be closer to the mic. Thanks. I was just saying there are some in the disability community who think it's time to move beyond that model and think more about equity and justice, about intersectionality with other identities. So I wonder if you have any thoughts on how that might fit into the work that you've done, and or if there's other ways to incorporate that perspective.
Yeah, it is indeed the next logical step. So I also find it interesting how our community partners are exactly on that page. So once the ICF was finished, the core set was finished, the World Federation and Deafblind International came to me and said, so you know what we need you to do next is to create a global definition of deafblindness. And I will give you a mini preview because we are literally writing the manuscript as we speak, and hopefully this gets submitted by Christmas. We are stealing the idea of autism spectrum disorder, and we're going to propose that deafblindness is defined as a deafblind spectrum, but that this is not a one-dimensional spectrum, because this spectrum is across severity, it is also across geography, it is across finance, it is across diagnosis. There are easily 10 items on which deafblindness is across the spectrum. Expressive and receptive communication, whether they're tactile, visual, or auditory. There's so many different ways. And that is where we get to the question of identity, because it is among and in between those spaces that people perceive themselves recognized and reflected in what we say. I'll give you a funny political piece in here that I have to negotiate. It turns out I am not deafblind, but I find myself even today speaking on behalf of people that are living with vision and hearing disabilities. What do I know, right? The good news here is that I've probably met more deafblind people than many others. So I am enriched by their perspectives, but at the same time, I am the wrong person to speak on their behalf. I was recently nominated by Deafblind International to represent them at the WHO Forum of Disability. So now I get to be part of a global conversation on this topic. At the same time, when I was appointed, I said, we need a second person who lives with a disability. And so the World Federation is putting forward somebody who is actually deafblind. And it's now our responsibility to speak with one voice. I think that also gives a certain credibility to the work that we do, credibility to why we're doing this. But I'm the first one to step back and say, I will bring you the information, but it is not actually about me. Right? It's a difficult and sometimes very thin ice situation, because you need to be very careful not to assume too much. And yeah, for any of you who are working in that space, you know exactly what I'm talking about, right? It comes back to the publication bias, and it comes back to the global South versus the global North. Not everybody is around the table. Even if they are around the table, in this case, they're literally not heard, or they can't hear what's going on. So this is a complex situation, but at the same time, I'm really drawn towards this complexity, because I think there is a diplomacy and a respect that we need to make this happen. And the progress we've made in the last 4 years is stunning. To see how people communicate with each other now that were opposed to be at the same team at the same time, because you are hearing and I am sighted and this doesn't make any sense. And some of this is still there, but it's much better than it used to be.
Fantastic, Walter. Thank you so much. Looking at time, I want to thank everyone for joining us today. I think we'll wrap up the official seminar here by thanking Dr. Wittich one more time for joining us. And then our trainees will have a discussion with Dr. Wittich following. So thank you so much, Walter.
Excellent. Thank you so much. Thank you.
Dr.
funny.
Wittich, you should have a new link in your calendar invite. You should have a new link. So I'll log us off here, but in your in the calendar invite you should have a new Zoom link to.
All right. I will look for my new link. Bye now.
Thank you.
Thank you.